Hello, um, and welcome. I'm very pleased to see you for supporting your teen addressing depression and eating disorders together, which is a webinar that is being presented by Families for Depression Awareness in collaboration with the National Eating Disorders Association. I'm Susan Weinstein, and I'm Executive Director at Families for Depression Awareness. And just on behalf of my team and all, we appreciate you taking the time from your busy day or evening to learn about the intersection of depression and eating disorders in teens and how you can help. You can expect the webinar to run for about 90 minutes, including questions and answers, which we will do after the main presentation. As you probably already know, this webinar is being recorded. We will send the link to each person who has registered for the program. You'll receive an email in about 24 hours, and you'll be able to access the webinar, so don't stress if you need to step away or you'd like to share the webinar with someone who wasn't able to attend. So in addition to watching and listening, there are a few ways for you to participate in the webinar. First, we use the question and answer feature, or the Q&A as it is. Use that to submit your questions. If, however, you submitted your question with your registration, you don't need to submit it again. I have the whole list. We'll have those and the ones from during the webinar during the question and answer period, and that'll be in about an hour. Second, please feel free to use the chat, which I see people already doing. Yay. Why don't you start off by telling us your name and where you're joining from, or even just where you're joining from. Just so you know, I'm in Massachusetts, just west of Boston. I'm eager to see where you are. In the chat, we really invite you to share resources, whether they're books you recommend, helpful organizations, support groups, other things at all. Oh, that's so nice. Somebody from Rhode Island, yay. It all helps. We're a community here. We really want to help each other. The one thing, though, is please do not share personal information about your teen or any particular named treatment, medication, or healthcare provider. It doesn't really help anything, and it could be detrimental. So an FFDA staff member will be monitoring the chat and also will be adding to it. So keep your chat open. You'll be able to download the presentation slides and other resources. So keep that open. Third, after the webinar, please take a few minutes to complete our survey. We want to know what we've done well, where we can improve, and what other topics you'd like us to address. We really depend on feedback and input from program participants and caregivers and others to help us figure out what kind of programming is really needed and wanted. So please feel free to be blunt and just let us know. As a small incentive, we'll send a $15 gift card to one person who completes their survey. It'll be chosen at random. We've also learned that our webinar participants enjoy participating in polls, so we'll have a few coming your way during the live session. In fact, let's get one going now. The question is, how confident do you feel in your knowledge? Sorry, how confident are you about supporting a teen with depression and an eating disorder? You can be very confident. I understand these topics well. Somewhat confident. I know a bit, but there's more to learn. Not very confident. I only know a little. Not at all confident. I don't know much or anything about them. And while you are doing that, I will tell you a little bit about Families for Depression Awareness, which here on out, I'll probably just call FFDA. FFDA helps families recognize and cope with depression and bipolar disorder to get people well and prevent suicides. I've said that more than once. We particularly focus on reaching caregivers because they hold a unique place in promoting their family's mental wellness and preventing suicides. To us, they're among the most likely to notice when a loved one is not doing well. They are highly motivated to act, and they will go to great lengths to marshal the resources needed to get their loved one the care they need and deserve. We also know that when one person is experiencing depression or bipolar disorder, it can have a ripple effect on their family. People get more that they have to take care of, they're worried, they're overwhelmed. So we believe that everyone deserves to have their needs identified and addressed. That's still going, I'll just say. Although we're based in Massachusetts, we've been doing national outreach to reduce the stigma of mental health conditions and educate people so they can support those they care about since our founding in 2001. We've been doing webinars since 2010, far ahead of the COVID-induced webinar craze. Many of our webinars are available on our website at familyaware.org/trainings and on our YouTube channel, which is FFDA1, the number one. At familyaware.org, you'll find a trove of education and information specifically for family caregivers, including actionable advice so that you can take the next step. We have online tests and tools, including a depression and bipolar disorder screener, which actually is only validated for 18 and up. A caregiver stress test that gives helpful tips to lower your stress level, because we already know you're stressed. Our mental health family tree to help trace, in particular, bipolar disorder, and our newly updated postpartum depression screener. We've always centered on storytelling, so you'll also find personal and family stories that educate, inspire, and help lessen the sense that you are in this alone. Stay up to date with our programs and new website content by subscribing to our newsletter. You can scan the QR code or just go to our website at familyaware.org and scroll down, and that's where the newsletter sign up is. Let's take a quick look at the poll results. Looks like we have a very small number who are very confident. We've got a good number, almost half, that are somewhat confident, just a little bit less than half that are not very confident, and we've got a few that are not at all confident. So hopefully people will be moving up when we ask you again at the end of the program. All right, we can close that out. And at this point, I would like to bring in Shivani Dutt to tell you a little bit about the National Eating Disorders Association.
Thanks so
Hi,
much,
Shivani.
Hi, thanks so much, Susan. Well, I'm super excited for this presentation, and I really appreciate the opportunity to share such important information and resources for everyone attending. So thank you all so much for being here. Before we pass it to Rocio, I'd love to share a little bit about the work that we do at NEDA and some resources that I think would be incredibly helpful to keep in mind post-webinar. So NEDA is a nonprofit organization working to fundamentally change the way eating disorders are understood and treated, and to empower those affected to achieve lasting well-being and recovery. So through our campaigns like Eating Disorders Awareness Week and National Eating Disorders Screening Week, we're working to increase public understanding of these complex disorders. Our Grace Hall and Cozy Resource Center connects individuals and loved ones with critical knowledge and lived experiences to help find help and support that they need to navigate through all stages of the recovery journey. We also educate communities through our Understanding Eating Disorders presentation, which was hosted in corporate settings, schools, and other nonprofit organizations to help people recognize those early signs of an eating disorder and to gain skills on how to have compassionate conversations. We invest in groundbreaking research that helps to develop effective treatments, and we also promote early intervention through our online screening tool, which has helped over 1 million people. So there are actually two resources that I'd love to highlight. The first is our online screening tool. So our online screening tool is anonymous and it's appropriate for ages 13 and older. And essentially what it does, it helps determine if an individual is at risk for an eating disorder. And once completed, people are then connected to next step resources to help support help seeking. And some of those resources are our treatment directory with eating disorder specialists across the country, research participation opportunities, and tips on how to talk to someone about your eating behaviors. The tool is available both in English and Spanish. And similarly, another resource that we have that I think would be incredibly helpful for this audience is we have a parent toolkit, which helps caregivers start open and supportive conversations, learn about tips on how to encourage someone to seek treatment, tips to provide mealtime support, and also outlines the evaluation and treatment process, explains medical risks, offers questions to ask providers, guidelines for communication between schools and treatment teams, and also shares tips on advocating during medical visits. All of these wonderful resources can be found on our website, so feel free to use the QR code to look through these resources post-webinar, of course. I'm also happy to drop some links in the chat. Thank you all again. I'll be part of the Q&A, but I will pass it back to you, Susan.
Thank you so much. And for people who are maybe not seeing it, it's www.nationaleatingdisorders.org. Okay, so here's what you can expect tonight. We will talk some about depression. We'll talk some about eating disorders. We'll talk about depression and eating disorders. We'll talk about what to do. And then we'll have our questions and answers. And then we'll beg you to do our survey. So I'm excited to now introduce Rocio Avila Salinas, who is a social worker, and she is our featured presenter. Rocio is a bilingual and multicultural therapist who for the last 16 years has worked with people with mental health needs in the Central Texas region. Rocio earned her bachelor's and master's degrees from Texas State University San Marcos. Her experience includes managing clinical operations at multiple levels of care, including acute inpatient psychiatric and outpatient clinics. She has served on various hospital and company committees concerning bioethics, diversity, inclusion, and belonging, and specialty therapies. Rocio has extensive experience working with individuals with severe mental illness, complex trauma, eating disorders and disordered eating, obsessive compulsive disorder, and acute crisis intervention. Rocio is currently clinic director for Family Care Center Cedar Park location. Rocio is passionate about working with Latina-OX individuals and family systems and strives to educate, support, and empower others to promote healing. Rocio, we are grateful that you're here. I know you want to start off with a disclaimer about the audience, so I will turn it over to you now.
Thank you so much. And thank you for everyone that is in attendance and watching, and even for those that watch this post live and watch the recording. I'm always grateful for the fact that you have an interest, that you want to learn, and that you want to do something about it. And as someone who does the work day in and day out, I am always appreciative, and I don't take that lightly, that there are so many people ready, wanting, and willing to support. So, with that said, as we mentioned, this program is for caregivers, for families. I do believe I saw there are some supporters from schools, professionals, maybe clinicians. I did want to add, if there is an adolescent watching, and there might be some things that maybe sting or that seem like a little bit, oh my gosh, that's really resonating with me, or it's impacting me, to really reach out to a family member, an adult, a loved one, and to talk about it, especially if it's someone, whether it's an adolescent or even an adult. If any of this part resonates with you, please reach out to someone, go to the screener if you need to. But just, I highlight that because oftentimes in the work with eating disorders, there can be some things that come up when we start to talk about it. And so that's just, I like to think that as the little signals that might be going off. And the screening tool is a really great next step on top of talking to someone about it. Okay, so as Susan mentioned, we're going to get into the topic of depression first. So, depression in context, right? I wanted to share this bit of data about adolescents, between the ages of 12 to 17, and how, 20% have had at least one major depressive episode, and that the rates are higher among females compared to males, and there's a variety maybe of reasons there. Oftentimes we know that females will talk about what's going on from an emotion standpoint, or even relationship standpoint, social relationships even. And so I wanted to highlight that bit of information as we get into the topic of depression and why it is important to talk about depression and eating disorders and bring it all together. So, and the fact that this really affects everyone, while we're talking about adolescence and we look at the rates in females and males, depression, it's, as we've talked about, as Susan mentioned, right, in all the work that that FFDA does, it really it impacts people of different races, ages. It's global. Socioeconomic status, same thing as eating disorder. So there's a lot of overlap in that piece. Okay, we can go into what depression might look like, right? There are different types of depression, features, we could say, and depression impacts everyone from, what we see and we hear, right? The sadness, the emptiness, the mood, and how someone can present as maybe more irritable, more isolated, and it impacts functioning, right? So how someone interacts, how they're doing their day to day, and we've got those parts of depression that we see and we hear. Then we have the pieces of the symptoms, the side effects that we see, right? We can see people losing interest in activities. There's impact to weight, sleep, motivation to do things. Um, I like to bring up, as I'm talking about, there's the very much the clinical criteria that we see, that we know for as clinicians, that is what we call the DSM, or the manual that we use to diagnose. So we see the different types of depression, but then what I see, in in person, right, when I'm working with adolescents, is oftentimes what that looks like is maybe they're not spending time with friends, their grades are impacted, they really don't want to go to school. It might be, oh, really again. I really just want to stay home. And so they'll end up, the presentation can look a little different than just this straightforward black and white text. And so I like to give those real life examples of what I see, right? When I see an adolescent, maybe because the parents encourage them to seek treatment, or the adolescent was doing the work and finding help. So they might notice, okay, I'm not sleeping. Sometimes they notice the appetite, sometimes they don't. Sometimes they don't have interest in doing the things that they were doing, and they might drop out of activities. But they may lose friends. So there can be a variety of ways that this presents, and that's normally what I see. So we've got the criteria, we've got the signs, and then we've got the different things that we see, when someone shows up. So it's important to look out for changes in mood, right? If you notice your adolescent is maybe more irritable or on edge, or even anxious, or having anxious responses, there's been an impact to their sleep and to their appetite, if you happen to notice it, right? Sometimes we'll notice that adolescents might be not eating a whole lot, or might be eating more. I've had, sometimes parents come in with the concern of, they're eating a lot, they're depressed, and all they're doing is, like, they're eating in their room, or they're, maybe going in after everybody's asleep and eating snacks. And it can be confusing sometimes for parents. Like I mentioned before, the extracurricular activities and the academic performance can suffer. And then self-esteem. Sometimes there is this self-talk that, parents can hear. Maybe there's a change in confidence levels, and how their adolescent is referring to themselves as either, a friend to others, or in relationship to themselves. So it's important to pay attention to those, little things that can seem like they're just passing comments. And as I continue later, um, I'll share about the impact and the importance of how those comments can be signs of depression, but then also how they can also be an eating disorder. So as we're talking about depression and I'm sharing all of these contexts, these are all real life things that I see as a therapist in my day to day when an adolescent presents with depression. So now let's get into eating disorders and what those are. So,
Before you do that, we're putting up another poll.
okay.
How familiar are you with eating disorders? Just so we get a good barometer on people. The options are very, my family has personal experience, or I've learned about them somewhat. I know someone, or I've read about them. Not much. I haven't heard or read much specifically, or not at all. This is new to me. So if you want to go ahead and talk, that's fine. We'll give them a little bit of time to answer,
Okay. Yeah.
or if you want to breathe, whichever.
I'll give everyone just a few seconds.
Well, it
Okay.
looks like we've got good buy-in already. So
Okay. Awesome.
about a third of people are very familiar. Over 50% are somewhat familiar. About 10% are not particularly familiar, and there is at least one person that admits to this being new to them.
Wonderful. Love the 1%. Love the 1%. That's I love that. Okay. So eating disorders. Yes, this is, and obviously you hear me get excited. This will happen. So with eating disorders, I'm going to give the textbook version of the knowledge here. They're classified under feeding and eating disorders in the DSM, or that manual that I was talking about. There are different types that I will talk about in the next slide. And, there is also disordered eating, which is different from an eating disorder. And eating disorders are complicated. They can be caused by a variety of reasons, right? Like it says here, biological, psychological, sociocultural. Meaning, when we're doing the work, even as clinicians, we don't always, we know that we're not always going to have a clear cut, oh, this is why the eating disorder happened. And I think we've learned to lean into that area of gray and discomfort as clinicians, that we will take the eating disorder and we'll do the work to treat it, to get it as far away as possible. And but sometimes that is the biggest part for families in this like learning curve of eating disorders, and acceptance sometimes that there is not one clear cut reason why. It's just that this is what we have to do next. And if anything, if there's parents that this is something that is brand new to you, or you kind of have an idea of what an eating disorder might be, just know this, that it might be complicated, that there might not be a straightforward answer, but with a team and with treatment, it is possible to recover from this, and it is possible to treat this, and it is possible to get to a better place of understanding, even if we don't know the why. We can understand it, and we can take care of it, and we can handle it, and you'll get your kid back. And that is, I think, the main thing that I focus on when I first meet a family, especially when I'm doing the work with parents, of just letting you know that there is hope. And even, in doing the work, when we're working with depression and eating disorders, sometimes us as clinicians, we are going to hold on to that hope for you. And that's okay. So just know this, even if you don't understand it completely, you don't know the why, your care team who is trained in working with eating disorders will hold on to that hope for you until you reach the other side. And I'll talk about that in a case study that I'll bring up later. And like depression, eating disorders do not discriminate against gender, race, age, socioeconomic status. They're global. They don't, culture. There's no. It can impact anyone. Okay, so now we're going to get into the specifics here. There's going to be a lot of detail in these, as I'm going to go into each one and give detail. I do want to share that the NIDA website has all of this information and more. So if you are, wondering like, oh my gosh, I didn't catch the bit of binge eating, go to the website, you'll find the resources, you'll see all of the information there. So don't stress if you miss something. This is just to give context to the different types. And when I'm sharing about a little bit more about them, so that everyone's a little bit more familiar with the types. So the one that I'm going to start with is anorexia nervosa, right? And so we may have heard of this one, seen this one. This is the one that a lot of the times gets more media attention, honestly, because there's like such physical overtness, and that in the past, right? Not to get too much into the weeds here, but in the media portrayal of images of beauty standards and all of that has focused on what's called the thin ideal, right? And so that's where this disorder, I think, gets the most attention, because there's this overtness and thinness that is noticed. So this is basically consists of the restriction of proper nutrient intake relative to the requirements that the individual needs. So their intake of nutrients is less than what they need. So it will lead to low body weight. And a lot of the times, individuals with this diagnosis will have a fear of gaining weight along with a distorted body image, meaning that they do not feel that they are thin. They don't want to gain weight, and they don't actually see how serious the condition can be, especially when the eating disorder is very prevalent and just kind of like has taken over in that moment. There are subtypes. There's a restriction type where someone will lose weight primarily by dieting or fasting or excessive exercise. Then there is binge eating and purge type, which people will then also engage in intermittent binge eating and or purging behaviors. Then we have atypical anorexia. I do like to talk about this because this is a type of anorexia that sometimes, will get missed. And I've heard people say, but how can I have anorexia if my body and shape is normal or I'm in a larger body? This doesn't apply to me. And this is where it's important to provide education, and that this diagnosis of atypical anorexia, it's basically a person who can be living in a larger or normal sized body, and they become preoccupied with weight or shape, and they could lose a considerable amount of weight, but they still are in the range of their percentile. So somebody that's maybe in the 90th percentile, and because of the weight loss, they're in the 50th percentile, but they're still within that range. And so this one, it's important to not be deceived, especially for clinicians out there that are screening for this, to know that image, outward facing appearance is not the indicator, right? That there can be different types, and that anorexia can look different in different body types. Then we have bulimia nervosa, and that is an eating disorder where someone has regular episodes of eating large quantities amount of foods or binging, and then they can even experience loss of control, and then they try to use different ways, such as vomiting or laxatives, or to engage in the purging behaviors to prevent weight gain. So that is bulimia nervosa, and it's different from binge eating disorder. And so I'm going to get into that. So binge eating disorder is also serious and involves eating. It involves feeling like you can't stop eating, right? So that loss of control eating that I mentioned before. It can also involve eating much larger amounts of food than the norm, than what the person would normally eat. But a person with bulimia nervosa and a person with binge eating disorder will be different from a person than with binge eating disorder, is that in bulimia, when they binge, right, there might be this use of laxatives, or the basically the something to engage in the purge. With binge eating disorders, that's not always the case. And so someone can have a binge eating disorder and they might engage in a purge maybe once, but that's not usually what they do. And they might try to diet instead, or restrict sometimes to compensate for that binge, or they might engage in excessive exercise to compensate for that binge. So they basically manage this differently. I think what's important to name in many of these, that these are accompanied also by feelings of depression, and I'll get more into that. But with binge eating disorders, it stands out in that there's this, I just binged, I'm not going to engage in the purge, but now I feel so bad about this that now I feel this need to restrict, or now I have to go in and exercise excessively, because now I just feel so bad about it. And that bad really is excessive sadness, shame, and guilt. And so it's important to know that, right? And we'll get into that overlap of feelings and presentation a little later. Then we have orthorexia. Orthorexia is this focus on clean eating. I think we see that a lot, especially in social media. So many trends, so many movements, so many things about clean eating, dieting, this focus on nourishment and the type of nourishment that one should have. I think that's important to pay attention to. So there will be this focus on healthy eating, clean eating, and whatever the individual's dietary beliefs, or theories are based, are clean eating. Like it might vary on what that looks like, but nonetheless, the focus is on clean or healthy eating. And when someone cannot obtain that, then there's this emotional distress because they're just feeling so distressed that, like, I won't be able to eat like I'm clean if I go to this restaurant. I won't be able to eat the proper amount of food or the proper type of food because I'm traveling. And so there's this increased distress over the types of food, and the relationship with their image or their body is positive if they're in compliance with the food that they're eating, meaning that they ate clean. So it may not even impact the shape or size, but it's more of the relationship to the food of, was it clean or not? Was it healthy or not? And when it's not, there can be a lot of distress and disturbance around that, to the point where it could impact relationships with loved ones, with friends, even socially, if they're restricting their environment, their socialization in their environment, because there may not be clean options available. Then we have disordered eating. I often get asked, how is this different? How is this different from an eating disorder? So a disordered eating is there's a spectrum of what this looks like. And so there could be some symptoms, some behaviors that are similar to an eating disorder, but they're not at the same maybe intensity or frequency, or severity. And disordered eating can include restrictive eating or compulsive eating, or irregular eating patterns. And that could also be because of lifestyle. If someone's working long hours at a job, I worked in hospitals before, as Susan mentioned or shared, and I know how it's all too common, especially nurses that have 12-hour shifts, that there can be snacking along the way and maybe one big meal, and that's just the nature of the job that leads to that, or that can be conducive to that. So someone could end up with disordered eating simply because of lifestyle, culture, or variety, or both. And so it's important to know that that is different from disordered eating. However, disordered eating can lead someone down the path of an eating disorder, or it could become that, or it could create enough worry for someone that they feel the need to be screened for an eating disorder if they notice that their disordered eating patterns are impacted. And I will share that, in not some, a majority or a lot of adolescents that I've worked with, because of the schools, and I don't know what the school system is like in other states, but a lot of our adolescents nowadays have what are called like A and B days in their schools, meaning that their schedule changes from the different classes that they have, and their lunch hours, right? Their lunch is happening like at 11 in the morning sometimes, and now they don't have recess. And so it is very common for me to hear adolescents talk about, no, I don't have a problem with food. I don't have a problem with eating. However, I don't eat all of the time at my lunch hour because I'm not hungry, because it's at 11 in the morning, and either I'm doing schoolwork, or I'm going to tutoring, or I'm just trying to hang out with my friends. That's the only socialization that I get. So I end up talking a lot and I don't end up eating as much. I hear that very often. So then they may not report an eating disorder, meaning that they don't have problems with body image. They don't have problems with, they report eating maybe at night and snacking, maybe having breakfast. So they're saying, no, I'm eating, but they are eating at irregular times, right? And then sometimes when I dig a little bit more, I find that there is an eating disorder, and it's not just disordered eating. Sometimes I'm hearing how, because they're eating in this disordered manner, they're feeling irritable, they're feeling depressed, they're feeling anxious. They crash around their last period hours, like towards the end of the school day, and they're just not interested in those subject matters. And so then they're just, I don't want to go to school because I don't understand math, but then math is like 2 hours after lunch, the lunch where they did not eat. And so sometimes even that basic education around, like, let's let's stabilize or normalize the eating patterns first, and then let's see what happens. And then if I start to hear a lot of resistance, or I start to hear struggles with that, then that's when I start to consider, okay, this might be an eating disorder and not just a disordered eating pattern. And I share all of that like clinical kind of background to hopefully help explain a little bit of the difference in how I will consider one or the other. And a lot of it is just kind of assessing and continuing to assess as I'm listening or doing the work with one of an adolescent or a teen. Okay, now we're going to get into these combined depression and eating disorders. So this is, a statistic from an article that I pulled that I think paints a really good picture as to why even today, NIDA and FFDA came together to talk about this, because there is an intersection here. So, this article found this, 23 to 48% of adolescents had this co-occurring situation, right, of eating disorder and depression, and that there was a higher prevalence of patients, or it's a patients in the article, right, of adolescents with bulimia nervosa than those with anorexia nervosa. And so I think this is really, when we look at this statistic, right, it's significant of the co-occurrence in these. And I also like to mention that this is why sometimes an eating disorder can get missed. We see the co-occurring here, right? How the numbers are pretty high. And then I'll go into here into the signs and symptoms and how what I see, and then how it can get missed. So when looking at eating disorders and depression, we see a lot of similarities, right? We see changes in mood, appetite, sleep, functioning, and worry, right? Worry about, um, it could be worry about their perception of themselves, their friendships, worry about food and eating, the weight gain, body image, right? Again, relationships. And so all of these things can seem similar to someone who is depressed, especially in adolescence. When they're depressed and they're isolating, maybe not engaging with their friends as much. Sometimes there could be factors related to bullying or exclusion. Sometimes that can be internalized as, well, it's because of how I look, it's because of how I present. So then, it turns into, well, I don't want to do these things in front of my peers. I don't want to eat in front of other people. I'd rather socialize. I don't want to look a certain way because then I'm not going to be accepted. And, or, oh gosh, I've been told by my friends that I'm very grumpy or I'm always in a bad mood. I don't like that about myself. And then we see the changes in esteem and self-worth. And these are all things that I've heard from adolescents. So at times, many times when I'm working with an adolescent, the presentation or initial presentation that either the adolescent or the parents have brought them to therapy is because they first noticed depression, meaning they're not acting like themselves, they're isolating, they don't even want to join us at the table anymore, they don't want to go out to restaurants with us to eat, they're not hanging out with their friends. And so depression, it's like, oh my gosh, what's going on with my kiddo here? And so this will be the initial presentation. Then as I'm doing my assessment and I'm talking, something that I do by standard is ask about sleep and appetite. And then that's when I shared earlier about the disordered eating patterns. And then as I'm searching to see if there might be an eating disorder, that is when I will uncover the eating disorder. So the initial presentation is depression, sometimes anxiety, or sometimes depression and anxiety. And then as I'm digging, that's when I'm finding that eating disorder kind of, hiding in plain sight, as sometimes I say. And then we start to look into the why, right? Like what is this eating disorder doing here? What's its thing? And sometimes it's, I don't want to gain weight. I don't like how I look. I just, I engage in secret eating because I don't know why. And it just happens. But now I'm having, problems with my family because they don't understand what I'm doing, or I'm waking up at night to eat and I'm not sleeping. And so they carry a lot of this worry, anxiety, depression that is coming from the eating disorder, but that is being internalized as shame and guilt. And that can lead to feelings of deep sadness and emptiness, and just a lot of worry about, what do I do with this? What is this? I can't seem to control it. And that can be a very scary feeling for a young person, to feel like, I don't know what's going on with me. I can't control this and I don't know how to stop it. And I don't even know how to talk about it, because now we're talking about food. And that can seem very, like, either minimizing for some, of it's food, I'm not going to bring it up, or oh my gosh, it's food, I don't even know how to bring it up. Like, it seems very daunting. And I've often heard the feeling of doom, of like this doom of, like, I don't know what to do. And as I'm saying this, if anyone has done work with depression, right, it can all sound very similar, right? And if you know some about eating disorders, then this all sounds similar, which is why we see this intersect. And so it's important for today, if I had to say, like, what are some takeaways for me, I would say, if you're noticing the depression first, if you're noticing the anxiety first, right, then we have to consider that there could also be an eating disorder, especially if we're noticing all these other changes: mood, functioning, appetite. There's a lot of impact that if somebody isn't getting the adequate nutrition, or like I mentioned, if their lunchtime is at 11, and they may or may not get a lot of intake, and then they're expected to focus and function and perform in math and science later at the end of the day, that's a lot for a young person. And then if we add to that, now I'm not sleeping because I'm also depressed, that's way more, right? So I say all of this just to kind of describe that burden that I hear. And I like to share, like, an image of that, right? Of, like, this, we pile all of this onto a very young person that then can be, they're impressionable, right? And also sometimes struggle with even identifying how they're feeling. So I like to provide all of this information, not to scare anyone, but just to kind of paint a picture of how these two diagnoses intersect, how they can seem similar, but then also how they are each their own different thing. Okay. So I say all of that, right? And so now we go into um, the risk, right? The risk and why this is important and why we're talking about this. That same study identified that adolescents with major depressive disorder had a higher likelihood of suicidal ideation than those without eating disorders. And however, there were lower rates of suicide attempts. There were, though, self harm or self injurious behaviors that could also lead to, suicidal ideation. And so the risk factors here is that if we have major depressive disorder and we have an eating disorder, while the attempts of suicide might be less, the self injury, self harm is higher. And so we have to address both. And that's, I think, the messaging here, right? As we get into now, what do? We address both. Addressing depression alone won't resolve the eating disorder. Addressing the eating disorder alone won't resolve the depression, right? And we know that when we're working with eating disorders, that we have to treat all of the symptomology, because they will go hand in hand. And I think myself and probably a lot of clinicians, especially if we have clinicians connected today, that we use a car example of, what's driving the car. And when we have an eating disorder, the eating disorder can be driving the car, and depression can be on the passenger side, and the individual can be in the back seat just watching, or sometimes the individual is in the passenger seat watching the eating disorder and depression ride. And what we want to work towards is the individual is driving that car. The eating disorder hopefully is not in that car, And depression might be riding along, but it's somewhere in the back to where they may not even notice, right? And that car can look different, but ideally we'll have the individual driving the car more often. And, because recovery does look different for so many people, sometimes there might be days when the individual isn't driving the car. Again, we hold on to that hope. We don't lose hope. We just continue to work until the individual regains the steering wheel, right? And so that's something important to remember. Okay, so now we're going to go into what do we do with all of this?
And we're going to launch another poll.
Okay.
If I can, here I am. Okay, so which of these challenges do you think you'd face talking to your teen about their mental health? And you could choose more than one. Finding the right time and place, knowing what to say, worried about them being angry, worried about them being upset, worried about making them worse, and other, you can drop it in the chat. Are they receptive to the conversation? All right. Things are still shifting, but worried about embarrassing the teen. Yeah, well, for sure.
Yeah.
All right, so the leader here is knowing what to say, so that's good for us. And then finding the right time and place, worried about them being upset, and worried about making them worse are the three next clump. All right, we can stop sharing that.
Okay, so
And I'll
very
disappear.
valid concerns. Yeah, for sure. Okay, so what do we do? All right, so, and I do like to, title these as, okay, I suspect this, now what? Like, thank you for the information. Now what do I do with this? So, and this is really when I share this, this is in the work when there are times when I'm working with an adolescent and we're talking about depression and anxiety and I'm seeing the eating disorder present, meaning I'm peeling back the layers and I can see it. And this same concern about bringing it up, right? While the parent's perspective is very different from a clinician, I also understand because sometimes I do have to align with the parents first to be able to have the conversation with the adolescent of like, hey, this is what is going on, and now we need a care team. And so, and that would be news for the adolescent. I'm like, wait a minute, I thought I just had a therapist. Why do we need to do these other things? So, the how do I approach, what do I say, what do I do is very important in then doing the work of treating the eating disorder. So, the first part I would suggest is become educated. Everybody that's connected here today, you are taking this step in learning about what eating disorders are, how they might present, and what to do, right? So the education, when we educate ourselves and we are going to walk into a conversation way more prepared, versus if we're just kind of guessing, right? And even if you're guessing at the type of eating disorder, that's okay. There's a screener available, right? So you don't have to have it all figured out, but at least you have that knowledge of, you know what, I don't have it all figured out. I think this is what it might be. How about we do this thing and we just fill out the screener? So that's what I would say is the first step. The second part would be to, find a quiet time, a quiet neutral place. And I use the word neutral, and that is very intentional, meaning it's important to find a time when everybody's calm, when we're not stressed and we're not in crisis, and when everything is just kind of neutral, right? It doesn't have to be overtly positive either, just neutral. And it's important because we know how depression can impact the brain, right? And functioning and executive functioning and how we think. And then if we have an eating disorder where there may be maybe malnourishment or nourishment has been impacted, that's going to exacerbate any of that. So we need to find a neutral, quiet time because of brain functioning and processing. We want to be able to be impactful in the words that we use and not and really maybe add to stress or worry or anxiety. Now, if you bring this up and your loved one maybe shuts down a little bit, it could be that it's like something is stinging, like I said earlier, but and it's okay to just give it some time and then revisit, right? So you find that quiet, neutral time, and then you approach with curiosity. Hey, I like to say approach with curiosity and do some observation. As parents, you know your kiddos better than anybody else. So you can approach from observation. Hey, I've noticed that you're not really spending as much time with your friends as you used to. I noticed that you've been shooting me down when I invite you to dinner at whatever restaurant. I've noticed that you are just kind of, in your room a lot and you're not really doing movie night anymore. And what's going on there? How are you feeling? Is there anything that's going on that I don't know about? And just kind of ask curiously. Now, if you've noticed that your adolescent has changed their behavior around food, then it's okay to observe that behavior, but it's important to not minimize the observation. And what I mean by that is, let's say that you've noticed that your adolescent has maybe is not eating as much as they used to, and that they're telling you overtly, um, "Hey, I'm not going to eat this because it has too many calories. I'm not going to eat this many times a day anymore." And to not minimize that by saying, what's the big deal? It's just food. What's the big deal? It's you just need to eat. And so it's important to not use that type of language, because if there's an eating disorder, that eating disorder is going to kind of dig its heels and see and try to like pin your adolescent against you, in that it's like, okay, for the person that's experiencing the eating disorder, it's not just about, okay, let me just eat. It's not just about, it's just food. It's way more than that. It's way more complicated. It's way more intense. And the feelings, if there's fear of eating, if there's feelings of disgust when eating, those feelings are way bigger. That minimizing that, that a lot of the times when I'm working with someone with an eating disorder, they will say, trust me, if I could, I would. I wouldn't choose this if I could. And so saying those words can sometimes be minimizing, and it almost makes it almost makes it like the eating disorder will tell the teenager, see, they don't understand. See, they don't get it. They'll never understand. Right. And so that type of minimizing language is important to be mindful of. And if you happen to step in it and say, yes, why don't you just eat? It's always okay to take a pause and say, you know what, actually, this is probably more complicated than that. Help me understand. That's where you apply the curious lens. Help me understand. Or if they say it's not that easy, I get it. Help me understand. Right. So bringing up your concerns is not going to make it worse. And I think that's something that is important to remind parents, right? That if you notice this, if they're isolating, if they're already maybe irritable, if they're already even feeling angry because you've been mentioning it, bringing it up to offer support or to do something about it will not make it worse. And that a lot of the times your teen, your loved one, they want the help. They want to be supported. They just don't know how to ask for it. And so if you initiate, if you come prepared with, self-education, if you come prepared with curiosity, if you come prepared with support, bringing up concerns is not going to make it worse. They're actually probably going to feel some relief in that, okay, I don't have to be the one to initiate this conversation, because now either mom or dad or, school counselor, right, is bringing up an observation now. And now I can talk to someone about it. That's a lot of the times things that I hear. Like I said, somebody will show up with depression, anxiety, and as we're talking about the eating disorder and I start to bring up, hey, have you noticed this or that, or have you noticed that you're feeling a lot of worry around eating, or that you don't want to eat in front of others because you don't want others to see you eating it. And sometimes the adolescent will tell me like, yeah, it's kind of weird, I don't know, how to bring that up, and me bringing it up helps them feel a little bit seen and like, okay, like this is okay, somebody gets this, this isn't just me, right? And it normalizes it a little bit for them to then be able to talk about it. That's stigma reduction, right? That's super important. So those are all different ways that we can approach and bring up this conversation that can be sensitive. Even if there is some reaction or reactivity, you can always take a pause, you can always regroup, you can always refer to the resources. Like I said, the screener, right? Especially if someone is a little bit more hesitant, you can even just say, you know what, I'm going to send you this link. Maybe you don't want to talk about it, but just check it out. Just check it out. Okay, so then we can talk about now some interventions, right? Now the different this on this slide we have a lot of information about the different levels of support, and each one has more specifics to them, right? And when I describe the levels of support, I like to use the triangle, right? The acute is like the top of the triangle. The most intense acute intervention would be some kind of acute inpatient hospitalization or a program, right? There are different centers in the country, even international, that provide this level of service. Then we have residential, and then we have a partial hospitalization program where someone will go, maybe 5 or 7 days a week. They'll be there receiving therapy and meals. And so they're there getting a lot of structured support, but then they go home at the end of the day. Then there's intensive outpatient, which is similar to the PHP, but not as intense. It might be a shortened day or a half day. And then we have the outpatient, which I would say then take a look on the side, right, where it says eating disorder trained care team. That is your outpatient care team. So it's important that you have someone that is trained in eating disorder from the psychiatry, therapy, and registered dietitian levels of support. And so when I was talking about, having this conversation with an adolescent and talking to the parents, and then we're talking to the adolescent together, it's because oftentimes we are the ones that have to then tell this adolescent, guess what? Now you have to meet with a psychiatrist and you have to meet with a registered dietitian. And sometimes the adolescent will be like, whoa, wait a minute. This isn't what I signed up for. I said I was depressed. I said I was anxious. Why are we doing this? And then we have to do this work of also providing more education in that there are these subspecialties for a reason, and that we're going to have to work with in treating this eating disorder from this comprehensive approach. It can't doing it one person doing it alone can be very difficult. And a lot of the times if we hold it alone, it's so that we can then bring in others. I added the external support because that is just as important. Having external support, such as community support groups, attending, NIDA website has like the campus warriors, the care fairs, like there are different community level supports that not only can the, in this case, the identified client participate in, but also the family, because the treatment approach of an eating disorder is often involves family. And and again, that comprehensive team, I probably should have moved family under the care team. There's the trained professionals, but family is just as important, and family is the identified family. There could also be other specialties like pediatricians that might identify this, sometimes endocrinologists. But it is important to have these conversations with uh, specific care teams, if especially if there are specialty providers, like I said, endocrinologists, pediatricians, a variety of specialists, cardiology. It's important to bring them into the picture if there is an eating disorder, to explain, okay, now we've uncovered this, you need to know this. And so we need to keep everybody in the loop. Okay, so now I'm going to share about we call it case study. I really like to consider this like storytelling, because there's a formal case study presentation, right, that we do as clinicians, but really this is where the work comes to life, I think, in sharing about real life examples. So I'll share a story, and I will try to not include too much identifying information for privacy purposes. But I'll just basically kind of give a picture, right, of how, of really a kiddo that presented with depression. So I'll start, right? This is an adolescent female, and who was about 13, 14 at the time, and presented for treatment of depression and anger and conduct or defiance type of behaviors that were happening at home and at school. School had already moved them into basically, they were recommending that the kiddo get moved into a charter or specialty school because of the defiance that was happening in school and the anger and the resistance with teachers, that they were already moving them into, okay, they're going to have to go to a different school. They can't attend here anymore. And so when all of that was happening, the family said, okay, let's get this kiddo into therapy. Let's talk about the anger. Let's talk about the depression. The adolescent was self-harming, had changed their attire. They went from like normal dress wear to always wearing baggy clothes, mostly black. And they often would put like their hair in front of their face so that their face, it was hard to see their face. And so they would not engage with the family at meal times, and instead were snacking a lot. And if they were asked to eat with the family, there was a lot of anger. And to the point where the parents were just like, you know what, we're not even going to deal with this. Like, fine, if you want to eat whenever you're eating, that's fine. And the adolescent would say that the younger siblings would annoy them. And so, they were like, no, I don't want to eat with everybody because the kids are so loud and they're annoying me. And it's just, I don't like that. And so this was also a blended, a family, a kiddo that came from a blended family. So mom was remarried with a husband and younger kids, and then dad was in his own home, not remarried. He was single, no other kids. So this kiddo had two different homes, two different lifestyles in each home, because on mom's side there was other children, there was some caretaking that was happening or that was being put on this adolescent. And at dad's home, they had their own room, they had their privacy. Dad was also very focused on clean eating and more of a natural lifestyle. So a lot of the approach to the depression was, let's go run, let's go outside, let's get some sunlight, stop wearing black. Like that was like what dad knew to do. And on mom's side, it was, let's go to therapy, let's talk about medicine. And, dad wasn't always a fan. And this kiddo was kind of caught in between all of this. And so as I was doing the work, the pediatrician brought up to the family, by the way, your daughter has dropped a lot of weight, and probably because of depression. I'm not really sure, but just so that you know, basically. And so mom brought it up to dad. Dad thought, no, this is normal. Anyway, there was a disagreement in whether that was a concern or not. I was working with the anger and the rage and the depression. At least that's what I thought. And so, I remember one day in a session, I just asked, how are you feeling? And the response was literally, I'm filled with rage. And I was like, okay, this is going to get really interesting today. And so we talked about, or I remember trying to talk. There was a lot of silence initially. And as we did the work, right, I began to uncover this eating disorder, and eventually did give this adolescent a diagnosis of anorexia restrictive type. There was no purging, and there was body image distress as well. And there was body image and there was anorexia, and the anger and the depression was stemming from the fact that the adolescent, when they would be at mom's home, they couldn't do all the things that they were doing at dad's home, which meant clean eating, calorie counting, excessive exercise, and basically engaging with the eating disorder. At mom's, there wasn't really a lot of privacy for that. So, and there wasn't accommodation for foods. It was just like, this is what we have, and this is what you get. And so there was a lot of distress there and a lot of anger. And so we were doing some work. This family, the dads didn't really interact with each other. They didn't really have a relationship, and there was a lot of siloing. And so a big part of my job was to bring the entire family together, to provide education about what was going on, and then to strategize, how are we going to support, what are we going to do. So the struggles initially were involving everyone, getting everybody on board. And then when I did say, let's bring the family, then, this was a Latino family, then it was, everybody was on board. I had, stepdad, bio mom, bio dad, aunt, a cousin eventually that joined, and everybody shared the link. And I was like, okay, this is going to be a big family session. But, I did say, bring family, whoever you consider to be family. And that's exactly what they did. So I said, okay, this is what we're going to do. So then the family work really became the entire family unit, right? Whoever was considered family. And because of that, I was able to get information about the different behaviors that this kiddo was engaging in, how they were isolating, where depression was showing up. And, and then obviously the kiddo was connected with a care team, with a psychiatrist, with a registered dietitian. They were given medication, they had a meal plan, and there was a full plan. And even to the point to where there was a family gathering, and the family gathering, before the event happened, the family asked for a family session. Everybody showed up except for the adolescent, and they really wanted to know, how can we host this party? It was a Latino party, with keeping in mind that we don't want to accommodate the eating disorder, but we also want to support. And so we talked about it, we strategized, everybody had a role, and then we presented it to the adolescent. And she was in shock that both dads were on board and talking, that the whole family came together to support her. And she was just like mind blowing. Later, after discharge, this kiddo did really well. After discharge, I got a message from the aunt, of this kiddo fully weight restored in her quinceañera outfit, and just thriving, thriving in school, getting good grades, had actually moved in with dad. And dad said, we are changing how we're doing things in this house. And but everybody was connected, and there was a relationship. And so it was really impactful to see how the treatment, of this eating disorder and the depression really led to life-changing outcomes for this adolescent. And so that's a really humbling example for me always, because of the impact of the work. And so that's basically a story of just one of many examples of how, when we hold on to this hope and then we hand it back over, and then the family lives with that, and that I think is beautiful.
Oh my God, that's so inspiring,
Yeah.
and moving. And I'm glad that it's not like the one that you have that
Right.
people can know that there are many success stories, and there are many times that families can really come together and be supportive of each other, and especially of their kids. I want to say a huge thank you, Rocio. That was awesome. That was so much information. And we wouldn't have been able to do this without Shivani and National Eating Disorders Association as well. So thank you guys so much for that. Please, everyone, stay with us for questions and answers. I think we have another poll coming up. That is the repeat of the one that we did earlier, but how confident are you about supporting a teen with depression and an eating disorder? You all can read the answers, and while you're doing that, I will say, please stay with us for questions and answers. This is the link to the survey, and you'll also find it in the chat. We will be giving away a $15 gift card, which, okay. But we also would not be able to do this Without our funders, the Massachusetts Department of Public Health Suicide Prevention Program, the George Harrington Trust, the Middlesex Savings Charitable Foundation, the Thomas Anthony Pappas Charitable Foundation, the Rebecca Pomeroy Foundation, the Bennett Family Foundation, and generous people like you. If you are able to support our work, please go to familyaware.org/donate. We very much appreciate anything that you can give. But we are able to do these for free thanks to our funders. Let's see. It looks like people moved up, so that's awesome. About 2/3 of the people feel somewhat confident. They know there's more to learn, which of course that's accurate. And about 1/3 of the people are very confident. Wonderful. Thank you all so much for participating in the polls. All right. We will now go to our questions and answers, and I will stop sharing the slides. And I'll invite Shivani to come back as well. But we're going to do like a little bit of rapid fire because we have a whole lot of questions and we're not going to get to all of them, but we will do our best. What assessment tools are used for eating disorders? Rocio.
Okay. I was about to say, okay, Shivani. So we normally, like we mentioned, that we have the NEDA screener, right? And that is the initial screener. Oftentimes we use what's called the EDEQ in treatment, in provide there are different screeners available. I think that's one of the more common ones that clinicians will issue. I don't know from a pediatric standpoint in a doctor's office, they might use growth charts, BMI as indicators to then refer. And so it just depends on the touch point, right? In schools, there might be also like maybe they're evaluating for depression and anxiety, like the PHQ-9 or the G87. And then from there, they might refer out. That could also apply to clinicians that are not trained in eating disorders. They might apply the PHQ-9 and the G87, which measure depression and anxiety. And depending on how they're scoring and what they're reporting, they might then initiate or issue the EDEQ, or they might refer out. So I think the touch point is important and where it starts.
That was a whole lot of letters. Okay. And a few numbers. Is an eating disorder considered an addiction?
I would say no. An eating disorder is its own diagnostic, not an addiction. I think that there is that common misconception that that it's an addiction, whether it's an addiction to food, right? Depending on the type of eating disorder, or like the even when I mentioned orthorexia, like the focus on clean eating, right? That sometimes that can be misperceived as maybe someone is addicted to that lifestyle, but it's really the absence of the distress of, if I don't do these things, that distress is so great that there's no pleasure from it. Like that reward system isn't like in like how we see in addiction, right? Where there's like that dopamine hit, that's different. There's a lot of distress, a lot of disturbance, and a lot of discomfort with eating disorders that's why I say a lot of people will say, no, if I could wave a magic wand and make this go away, I would.
Is there a connection to OCD?
We do see some overlap. I do work with OCD, and I will see some overlap. I think that OCD sometimes can get a little tricky, and that there can be rules that it'll form. But when we do the OCD work, we can tackle those. Now, when there's an eating disorder and OCD together, they're comorbid, then that's a whole different approach, right? In that now we're dealing with two different diagnoses, but that interconnect, kind of like with depression, right? And the same thing about substance use, right? That sometimes that is present with eating disorders, but it's comorbid. Same thing with OCD. We tend to see sometimes that perfectionism, the rules, that it can seem similar, but they're each their own diagnostics.
Awesome. Someone asked about the difference between sporadic sadness and depression, and I think I can answer that depression is a set of symptoms that affect functionality, but there are different ones that need to be met. and that it persists for at least 2 weeks. So if someone is having sporadic sadness, that's sadness, and that doesn't mean that they can't benefit from seeing a therapist, but it probably would not be diagnosed as depression. Is that okay? How do you get help for a teen who thinks they don't need it?
Oh, that's always fun. Yes. So, I think that is a great question. How do you get help? One, initiating the conversation, right? Like I said, observing the behavior of the why you think they might need help. And if they're very resistant, I think the curiosity is really helpful. Sometimes I'll even ask, when I'm doing the work and I'm talking to an adolescent and we talk about their pattern of eating, or maybe their lack of eating because they're so busy and all the things. I will ask, okay, do you ever have a hard time with eating around your friends? And if they say, well, yes, and if it starts to impact their social life, meaning they're not joining their friends at certain outings and things like that, then I use that as an opportunity to say, well, wouldn't you like to change that? What do we do with that? And so sometimes we have to find the areas that they might still be motivated in wanting to do, to create some separation between the eating disorder and the adolescent, right? Like, and say, like, this is coming in to impact you and impede you from doing the things that you want. What are some things that you want to do? And then approaching from that angle.
Yeah, we always recommend going with observations and expressing concern, and
Mhm.
that there are things that can be done to improve
Mhm.
the situation, and that you're there when they're ready for it, and just
Right.
encouraging them. We're in agreement. Shivani, are you aware of any successful public health campaigns about prevention and recovery and support for eating disorders?
Yeah, so one campaign I think that's most successful is National Eating Disorders Awareness Week. So that typically takes place the last week of February each year. So in 2026, it'll be February 23rd through March 1st. So essentially, during that campaign, the entire eating disorders community informs the public about the realities behind eating disorders, specifically through social media. And we'll also find that people will hold in person, virtual education community events across the country. So we'll see experts in the field and people with lived experience come together to debunk myths, share the lived experience to help make people feel less alone and seen. And there is usually an advocacy component. So, for example, last year we'd encouraged our community to email their state representatives to include eating disorders education in every mental health curriculum across the country. We've all been in high school, and I personally don't remember ever getting much eating disorders education in my health class. So that's really important for us moving forward. There are just still so many myths about eating disorders, including who can experience them, how serious they are, and what causes them. So, our goal with that campaign is to center the conversation around the truths to support early detection, to get people connected to resources so that they can get help, and to also create spaces where people can get compassionate support.
Thank you. Um, what can someone who's not a parent say when a teen in their life says, do I look fat? Or, um, you know, I think I don't look good. Are there ways to approach that in a constructive manner? Rocio?
Yeah, so a lot of the times when I first work with a family, I will begin by asking, if we can cut out any body related comments, and because sometimes that happens. In Latino families, there's a lot of nicknames that we use and that are directly related to somebody's appearance, whether it's in size or shape or colorism. right? So we definitely, that's the first part that I ask families first, where, because if the kiddo's bringing it up, I'm always wondering, okay, where did this begin? Why is it here? So the first step is to inform families, like, can we change this in the household? Then, I like to approach, okay, asking, that's where I think the curiosity part of, why is this coming up? Why is this a concern for you? Like, if somebody says, do I look fat? It's like, whoa, okay, that came out of nowhere. Or maybe you've been saying that a lot. Like, where is this coming from? Why is this impacting you? And a lot of the work that we do is more around centered around values. And, and instead of focusing on it, but it's also, I don't like to just say, well, no, you're fine. Like, no, like, you're this great person and these are the great things that you bring to the table. I would not want to minimize the concern about the question behind the question, right? So then that's an opportunity of intervention, I think. So really the response is intervention, in my opinion, right? It's yes, we can talk about how the great qualities that the individual has, but to me, that's an indicator of, I'm trying to say something more here. I'm not just asking, do I look fat? I'm asking, am I worthy? Am I worthy of time, attention, socialization, and how do you perceive me? Do you love me? Like, those are the questions that are really underlying from beneath that, right? And sometimes validating the individual helps, but I think oftentimes that's the opportunity for connection. And I often do, when I have kiddos that will tell me, well, I just think I look fat. And that in session, right? If we've already established a relationship and they're bringing it up and that's their concern, then I shift into values work, and focusing on, okay, let's talk about image. And there's different exercises that we do around the values piece, and where they're worthy as people, lies, their worthiness lies, and it's in those values that they hold inside of them. It doesn't matter what the outside looks like.
Thank you. Um, Shivani, I think that you might have something on this because it probably has to do with volunteering. Someone asked, how can my recovering teen educate her peers on eating disorders?
Yeah,
And Rocio,
that's
you're welcome to chime in too, but I thought,
yeah, of course. Well, it's amazing to hear. I think it's always awesome when people want to use their recovery journey to help raise awareness and build safe spaces for their fellow peers. So just kind of a plug for our work, I suppose. But we have an understanding eating disorders presentation. I know I briefly brought this up in our intro, but we've had students, use some health classes or like free space in auditoriums to host the session. And essentially, it's kind of like a 101 training. It's meant for lay audiences. So adolescents are they can understand the materials. So essentially, the presentation goes over the warning signs, the facts about eating disorders, tips on how to talk to someone that you're concerned about, and also our resources. I find that to be a great intro so that people can get an understanding of what to look for within their peers and also know how to support their fellow peers. So that's one way. We do also have a lot of shareable resources on our website too. We have a bunch of flyers. I know people love to have things on hand. I can drop all of this in the chat, but we have flyers on warning signs, the truths. I know we didn't go too deep into this, but how to challenge diet culture, because that plays a really critical part, especially for adolescents as they're developing their identities in that age. So I always encourage people to print out our flyers and post them across their schools, whether it be like in their counseling centers. I know there's a bunch of bulletin boards. Um, Also, social media is a great place. I know that there's a lot of negativity around social media, but it's also a place where people can build communities. I've seen a lot of teenagers start Instagram accounts related to eating disorders awareness. So people can, cite the resources on our website and kind of develop their own graphics on resources and general information about eating disorders. So those are kind of the big ways people can get involved, especially as adolescents.
Perfect. Um, uh, and while I have you, what's the best way to find resources for um, treatment for eating disorders or supports? I mean, including for places that are remote.
Right. So I know I dropped this in the chat, but Nina does have a treatment directory. We just relaunched and made it super user friendly. So we know that eating disorders don't happen by themselves. And treatment also has to be super personalized. So I will also drop this in the chat, but when you go to our directory, there are filters where you can search for providers who treat teenagers, co-occurring anxiety, depression. And we know post-pandemic, a lot more providers have been getting licenses in other states. So there is also a really robust virtual provider list on there. And not only therapists, dietitians, individual providers, but there are also treatment centers that offer higher level of care, such as intensive outpatient. So there are also treatment centers that are doing virtual IOP. So please feel free to head on over to our website to find those resources. Again, I do think the move to virtual has been really helpful for rural areas because there are a lot of treatment deserts when it comes to eating disorder specialists.
Agreed. Just so a noting that Jessica put in the chat, we have a teen in Central Texas who created bookmarks to put in places all over Central Texas about eating disorder awareness. So congratulations to her. Um, there are some questions about eating disorders and ADHD or other neurodivergent issues. Someone said, could you comment on ties between eating disorders and ADHD, anxiety, and depression? Seen stats linking eating disorders to those with ADHD and at high rates, and many medications affect weight and or hunger. So there's a whole lot of question for you.
Yeah. And I was scanning the chat, and yes, I also saw the comment about ARFID, that I did not get into ARFID. That is also another type of eating disorder that is very, the way it presents, right, is very specific. And so again, we keep mentioning the NIDA website, but really truly is packed with resources and information that I would say go in there and learn and read more about all of these things. As far as ADHD, yes, I have also seen that relationship comorbidity, right? In that some of the medications do play a role. And this is why that care team is so important, because someone, can be experiencing ADHD and truly need medication for it. And then it starts to impact their appetite. And then if there's an eating disorder, there might be this tendency to say, well, okay, we're okay with this. This is like, this is what the eating disorder wants, right? But then the psychiatrist, the care team, everyone needs to be involved, because even though, I've worked with folks with ADHD and eating disorders, and we literally, create calendars, just not to get too much into the treatment approaches. And that's why it's kind of hard when we do these intro 101 types, right? That we don't get too much into the treatment approaches. But sometimes, I will have folks that will set alarms to eat, right? That will include it because ADHD is happening. And then, they might get caught up in whatever they're doing, and they need to engage in what's called mechanical eating. So then they don't have hunger cues, and they have to set alarms to eat. And then the medication has maybe side effects. And that's where the registered dietitian comes into play to create a meal plan appropriate to be able to support whatever the goal might be as far as nutrition. So we do see this correlation. And then I also see the relationship and how it plays out. And it's possible to treat both. It is important to treat both, actually, and to notice what's happening, and obviously someone with ADHD wants the support from that standpoint, but it's also important to tackle the eating disorder as well. And because I know we're not getting too much into the details of treatment approaches, I can't go too much into it, but I can say that yes, I've seen the relationship, the correlation, the comorbidity, and then we treat both.
All right, well, we are very much near the end of our time. But let me just ask this one. How can a family handle the ups and downs? It feels like 2 steps forward, 1 step back. Sometimes it's 1 step forward, 2 steps back.
Yes. And, if you have a care team, and speaking as someone who is part of a care team, sometimes we're going to hold that hope for you. Even when it might feel we've taken 2 steps back, now I'm scared, I'm feeling hopeless, I'm feeling afraid. You lean on that external support, you lean on your care team, because that's where the support is coming from, right? It takes a whole tribe to treat and to support someone. And that applies to all of us, right? Eating disorder or not. And so I think that when there is that, gosh, we've taken 2 steps back, lean on your support team, your people. And even for your loved one, for your kiddo, right? If they're feeling like, oh man, now I've taken 2 steps back. There are so many times when I connect, to meet with someone, whether they show up to session, and the first thing that they tell me is, this is what I did. Basically, I engaged with the eating disorder. And now, I have to start all over again. And oftentimes I remind them, no, that was a moment. That was a lapse. That was a moment. Today is today. Right now is right now. What are we going to do moving forward? Right. So even if it feels like 2 steps back, I bring them back to present, so that now we're talking about where we're moving from right now. So coming back to present, letting others hold the hope for you until you can pick it up again. I think those are important strategies when we're having these ebbs and flows.
There are a lot of questions that we didn't get to, but we will try to find a way to work with Nita to get some of these answers out there. Rocio and Shivani, thank you so much. Everybody who stuck with us, thank you, thank you. And please do give us your feedback and watch for our next webinar in the spring. Thank you all so much.